spend some time talking about managing suicide risk in the outpatient setting. Next slide. Okay. So I want to give you some perspective on the scope of this problem globally. Suicide is a global problem. Every year, about 800,000 people take their own lives, and then there are many more who attempt suicide. It's the second leading cause of death for young people between the ages of 15 to 29 worldwide. It's the leading cause of death for girls for ages 15 to 19 years. And of course, for each completed suicide, there's significantly more suicide attempts. So there's about 100 to 200 attempts for each successful suicide. But despite these numbers, only a few countries actually have suicide prevention as a national priority. Next slide. So what is the burden of mental health and suicide globally? So we know that adolescents make up about 25% of the world's population, and the recent estimates suggest that mental health conditions are prevalent among about 10 to 20% of adolescents. We actually believe the numbers are higher in lower and middle income countries. We also estimate that about 50% of the global burden of disease has its onset during adolescence. We believe that about 16% of that is attributable to mental health conditions, which is actually significant. Now, of course, it's important to remember that suicide itself is a low prevalence event. So there's only about 4 suicides per 100,000 for 10 to 19-year-olds, and then about 6 per 100,000 for 15 to 19-year-olds, although any one life lost to suicide is a tragedy. There are variations in suicide prevalence across countries. So most of the data that we have is actually for Western countries. But despite the fact that we know it's happening across the world, as I mentioned, only about 28 countries have a national suicide prevention strategy. Next slide. So, as I mentioned, most of the global suicide rates reflect Europe and North America. That being said, it doesn't mean that it doesn't happen in other countries. But other countries collect data on suicide at a much lower rate. So currently, we have very little data on low and middle income countries, which is significant because most people live in low and middle income countries. We estimate that about 75% of the suicides that occur in the world actually occur in low and middle income countries. But what we have thus far, based on Western countries, suggests that even in those countries, there's a need for a suicide prevention strategy. So what do we know about low and middle income countries? So in one study, looking specifically at that question, in 40 lower and middle income countries, Liu and colleagues used a global school-based student health survey, looking at the years between 2009 and 2013. So most of these national surveys, like in the US and in other countries, collect data yearly to every 2 years on just random non-clinical samples of adolescents, and they ask about a series of potential health risk behaviors, such as using substances, engaging in sexual activity, carrying a weapon. This study used a similar type of survey, and data were extracted from the surveys for 12 to 18-year-olds to try to determine what are the suicide rates and what are the associated factors. What the investigators found is that when they looked at a year of data for suicide attempts, the prevalence was about 17%. They also discovered that the suicide attempt rate was higher for girls than for boys, which is true in most countries. They also discovered that the proportion of suicide attempts with a plan was higher for girls than for boys. But they also observed that for both groups, as the adolescents became older, so starting from 12, as they moved up to 14, 15 through 18, the number of suicide attempts with the plan increased. They also wanted to look at what are factors that might contribute to suicidality. And what they discovered is that poor socioeconomic status, bullying, loneliness, anxiety, young people who use tobacco and alcohol, and young people who had conflict family relationships or poor social relationships with their friends. Next slide, please. So in another study, looking at the same database, but looking at more countries, Campisi and his colleagues looked at self-reported suicidal ideation and attempts in younger, and he classified younger adolescents as 13 to 15, and older adolescents, 16 to 17, in high-income and lower-middle-income countries. So it was a much more representative sample. They discovered in their studies that the prevalence estimates for those young people examined in that study, and it was a much larger sample, so it was close to 400,000 kids. They found that the rates varied significantly, so that in some countries they had a 1% prevalence rate, in other countries they had a 67% prevalence rate. But what they did find is across countries is that the rates were higher, the rates for ideation and attempts was higher for girls than for boys. And they didn't find differences by age or sex. What they did find, though, was that being bullied and having no close friends was associated with suicidal ideation among girls, 13 to 15, and then 16 to 17 years respectively, so both for younger and older girls. Among boys, what they discovered is that being in a physical fight and having no close friends was associated with suicidal ideation. And if in fact those boys had experienced or sustained a severe injury, the rates were even higher. And so the takeaway message from this study was that suicide rates exist, across upper, high income and lower middle income countries, but also that there's some risk factors that you might be able to identify for vulnerable youth, such as kids who have poor peer relationships, kids who have poor family relationships, and kids who have been bullied could be at increased risk, and those could be targets for intervention. Next slide, please. So one of the most important things for clinicians when talking about suicidality, we're learning, is using a common language to talk about suicide. So one of the things that has really confused our ability to collect data has been confusion around language. What does it mean when we say someone's suicidal? And we define these terms on a spectrum of low risk, which is a wish for death, to high risk, suicidal ideation with intent and plan. So when we talk about a wish, a wish specifies the desire to not be here anymore. For younger kids, they talk about wanting to fall asleep and not waking up. The next higher level is a non-specific active suicidal thoughts. So that's the thinking of, I want to kill myself, but I haven't really thought a lot about how I would do that or when I would do that. And then there's active suicidal ideation with a method but no intent or plan. So that could be a young person who says, I know my parents have a gun in the house, but I'm not sure that I'm going to use that. Active suicidal ideation with some intent without a plan. I think I want to die. I want to kill myself, but I haven't figured out how I'm going to do it. And at the highest end is suicidal ideation with intent and plan. I know I'm going to kill myself. I know my parents have a gun in the house. When they leave tonight to go to dinner, I plan to kill myself at 8 o'clock. And that's the highest level of risk. When we talk about suicidal behaviors, that's different than ideation. With suicidal behaviors, they also exist on a continuum from preparatory act to suicide attempt. So preparatory acts or acts preparing to imminently make a suicide attempt, which could be I'm writing letters to say goodbye to my friends. There are aborted, self-interrupted attempts. The person takes steps, but they stop themselves before they engage in any behavior. And then there are interrupted attempts. They made a plan, they started to engage in behavior. Someone else stopped them. And then the suicide attempt itself, they made the attempt with the intent to harm themselves, and they either died or they did not die. But suicide attempt, of course, is the highest level of risk. Next slide, please. So what does all of the findings tell us globally? Well, what we know is that suicide is not just a problem of Western countries, it's a worldwide problem, and it's a leading cause of death for adolescents 10 to 19 years of age. The rates vary widely. and the World Health Organization's mortality database have uneven data because some countries can collect more data than others. So we found that suicide rates are highest in Estonia, New Zealand, and Uzbekistan. But what we don't know is which groups had the highest suicide risk in New Zealand. Was it the minoritized populations of New Zealand? Was it the majority white populations of New Zealand? We don't have that data. We also know that suicide rates were higher among older adolescents compared with younger adolescents, and that overall, the rates of completed suicides are higher for males, but attempts occur more often in girls. The most common methods worldwide were hanging, suffocation, jumping or lying in front of a moving object like a train, or jumping from a height. And then we definitely know that firearm access and railway access are related to firearm suicide deaths, and jumping and lying in front of a moving object. They are the most common causes of death worldwide. Next slide. So why adolescents? Why does this happen more commonly in adolescents, and why do we focus on adolescents as the best period for prevention? And that happens for a couple of reasons. And one is that we've observed that the suicide rates tend to increase in early adolescence. So typically, suicidal ideation has its onset in early adolescence, around 10 to 13. And then of that group of young people who have ideation, only a subgroup will go on to develop suicidal behavior 2 to 3 years later. So it's not all of the kids who are having ideation as young adolescents, but there's a subgroup that will continue to have problems. We don't know why exactly it happens at this age group, but there are multiple different theories and observations about this developmental period that gives us some information. And adolescence is a period of development where you're actually able to think about and implement the act of suicide. We do know there are differences between younger and older adolescents. So increased suicidal thoughts and behaviors coincide with the time period where you see the onset of major psychiatric conditions like depression, bipolar disorder, which increase suicide risk. Older adolescents, in general, developmentally, take more risk than younger kids. So they engage in more risk-taking behaviors. And many of those risk-taking behaviors are associated with suicidal thoughts and behavior. There's also this thinking that the development of the amygdala in neurodevelopment happens at a faster rate than the executive functioning areas of the brain. So the level of emotion rises at a rate much faster than the level of their ability to control their impulses and their actions, which can result in risk-taking and dangerous behaviors. Older adolescents also develop highly complex abstract thinking, and it's a period of rapid cognitive development. You know, people are smarter as adolescents than maybe they are at most other phases of life, but it also increases your risk for complex and maladaptive thinking. And so there's a tendency to be able to think about the future, and if you have a negative cognitive mindset, the future can be negative. Negative thinking is associated with hopelessness. There's also a capacity for rumination, to overthink and ruminate about things. And so young people, just because of their cognitive abilities, are more capable of taking on negative, dysfunctional behaviors that can be harmful. And then the other major factor influencing suicidal behaviors is the development of peer relationships, which take priority during adolescence. And so with positive peers, kids do well. With negative peers, they take on more risky behavior, including modeling suicidal behavior, which we commonly see with contagion. Next slide. So what are we seeing in the United States? Well, you know, this is a curve that reflects trends from 1975 to 2015. And then what you'll notice is that we had a peak at around 1995, and we started to see a decline in suicide rates. We think probably associated with the timing of the development of Prozac and increased national focus on suicide prevention for young people. But as you can see, it's going up. It is still the second leading cause of death for adolescents in the U.S. And when we add up all the conditions of childhood that cause death, suicide supersedes all of them. And when we look at healthy samples of high school students in the United States, between 11 to 22% say they've considered suicide in the 12 months prior to the survey, similar to what we're seeing worldwide. Next slide. The other trends that we're observing in the United States that have been going on for quite some time, but we didn't really notice until the last couple of years, is that suicide rates are increasing for minoritized populations in the United States. So for Black, Hispanic, and Asian populations in the United States, suicide rates have been increasing while they've been stable for white youth in the United States, which signals that we found some successful ways to prevent suicide for white people, but not for other people. And so basically, this is information that was buried within our data for many years, and we're just now starting to get a better understanding of what's happening with youth across race and ethnic groups. Next slide. And then this diagram just gives you a little bit more detailed information about what's actually happening among racial groups in the United States. And this slide is so busy, it's hard to interpret from the slide. But the big takeaways is if you look at suicide attempts in the past year, which is area C, and if you look at the graph D, which is injury by suicide attempt, what you'll find is that for every other ethnic group, the rates of suicide attempts in the past year and injury by suicide attempt in the past year is higher for every other racial group and has remained relatively unchanged for white Americans. Next slide. So what do we know about youth who have successfully committed suicide? In this particular study by Triglitas and colleagues, it looked at psychiatric diagnosis found retrospectively on a chart review of over 700 youth who had successfully completed suicide. And in this sample of suicide completers, it was young children and adolescents. What they found is the majority of the young people who made a suicide attempt met criteria for depression. The other 20%, and this was a surprising finding, was that attention deficit hyperactivity disorder was the only risk factor or psychopathology identified for those youth who had successfully completed suicide, and about 16% actually had bipolar disorder. The 20% for ADHD is significant because impulsivity is associated with suicidality, and this is especially true for the children who are younger and under 12. Next slide. And then, of course, as we mentioned before, similar to worldwide data, hanging, suffocation was the most common cause of death, and then death with a firearm or a weapon was second. So what did we take away from all of the information that we have now? The rates are trending upwards globally, and that's become very visible across countries. The majority of youth who die by suicide have some evidence of serious psychopathology, with mood disorders conveying the greatest risk. So at 80% of attempters and 60% of completers, you'll find serious psychopathology. Attempts and plans are rare before 10, and then they start to increase between ages 12 to 15, and then more slowly through age 17. But as I mentioned before, and if you think back to the diagram, you see the ADHD kids who committed suicide. For children under 12, they're most often impulsive acts. And then remember, for every completed suicide, there's about 100 to 200 attempts. Females make more attempts and report higher rates of ideation, but boys are more successful in committing suicide than girls at a ratio of about 5 to 1. Next slide. And minoritized youth have higher rates of suicidal ideation and attempts. And I just want to highlight that even though hanging is the most common method, firearms are the most effective method. So almost any way you try to kill yourself other than with a gun gives you a chance of survival. So we're going to talk a little bit about risk factors. And in this busy diagram, the takeaway messages are that suicide is a multi-determined event. So there's typically not one thing that places people at risk for suicide. There are population risk factors, individual risk factors, and environmental factors. And so we've just experienced a major stressor from a population level with the pandemic. Rapid social change, economic turmoil, social isolation are population risk factors. Individual risk factors, which we commonly refer to as mental health professionals as predisposing factors, family history, family environment, developmental or mediating factors. So those are factors inherent to that young person. So for someone who's impulsive, someone who's anxious, someone who has some significant cognitive impairments, those are developmental or mediating factors. And then there are proximal or precipitating factors. Those are the things most closely linked to the suicide risk. So for example, for a young person who has family struggles, high anxiety and impulsivity, who has a stressful life event, they break up with their girlfriend or boyfriend, are at increased risk for suicide from multiple factors. And then there are other factors, environmental factors. So for the same kid who's hopeless, seeing media reports of suicide clusters could be a precipitant to a suicide attempt. Access to means and access to mental health care. Next slide. So what do we see clinically as risk factors? Well, a history of past suicide attempts is one of the greatest predictors of future suicide attempts. That's your highest risk group. And then the lethality of past attempts. So that about 40% of young people who make a suicide attempt and succeed have had a prior attempt. And I do want to highlight, most suicide completers are successful the first time they make an attempt. So any effort to any survival after a suicide attempt is an opportunity to prevent another one. And then suicidal ideation is a risk factor. Its presence, its frequency, severity. The higher the severity, the higher frequency, the greater risk. And even less severe risk, though. Let's take a kid who's low risk. In the presence of a firearm or a train track, their risks become higher. Other factors are acute stressors, loss of loved ones, loss of jobs, substance use, affective instability that can come with mood disorders or psychosis, people who tend to be impulsive and aggression. Individuals who have chronic medical conditions are at higher risk, especially if they have a medical condition that affects the nervous system. And then, of course, sleep is a risk factor for irritability and suicidality for those who are at risk. Other factors that are demographic, environmental, clinical is a family history, psychiatric illness with suicide. As I mentioned, exposure to a contagion of suicide in a community, access to lethal means, being an older teen, they tend to die more by suicide than younger ones. Boys are more likely to die than girls. And then a history of trauma, abuse, bullying, chronic family conflict, and what we're learning is that among minoritized youth populations, family conflict appears to be a greater stressor and precipitant for suicidality, particularly in younger minoritized youth. People who have gender non-conforming sexual identification, homelessness, legal problems, and the experience of racial discrimination or xenophobia, discrimination for any reason, is a risk factor for suicidal behavior. Other clinical symptoms are changes in clinical presentation, including new onset wish for death, suicidal ideation, or new onset self-injury, a new onset of feelings of hopelessness and no reason for living, worsening irritability, agitation, anxiety, and persistent sleep disruption. And then people who suddenly disconnect from their social and support networks or begin to engage in reckless or dangerous behavior. Now, what's really important, and I think an area of opportunity for mental health professionals, is understanding protective factors. We know much less about protective factors than we do about risk factors. But what we do know is that there are some things that decrease suicide risk, and we can use them when formulating a treatment plan. Some of those factors are engagement in treatment, restricted access to lethal means, good problem-solving skills, social connectedness with family and peers, family support and involvement, high-quality friendships, and all of these things together, when we use them in a plan to support a suicidal youth, are interventions that can enhance and protect the young person from overall suicide risk. So I'm going to hand it over to my colleague, Dr. Naeem, now to talk about the assessment.
Hello, everyone. My name is Dr. Ambreen Naeem. I am a medical director of a partial program at Children's Hospital of Philadelphia. And today I'm going to talk about suicide assessment and evidence-based intervention for suicide in youth. So there are times when you have to take a deeper dive and do a very thorough suicide assessment. And the question is, when do we do a very thorough suicide assessment? This can be when a patient screen positive for suicide ideation. This can be when you're doing your intake for the first time. This can be when you're following patient over time as an outpatient and there are some stressors going on, there are some transitions in their life, and patient has a known history of suicidal ideation. This is the time to assess for their current level of risk. So the goal is to identify the risk factors, especially those that can be modified and reduced, and identify the protective factors, especially those that can be enhanced. So what that means is, if you have a child who is suicidal and he has and the family circumstances are unsafe, that patient cannot go home. But if you have a patient and you're following that patient in your clinic and they have good protective factors, you can discharge that patient home, and because we know the interventions are more effective in outpatient setting. So how do we conduct a thorough suicide inquiry? So we look at current suicidal ideation, intent, and behavior. So this is a very important, because you are trying to take a collaborative approach and you are going to uncover moment to moment and try to see what are the cognitive, psychological, and circumstantial drivers of their suicide risk. And you also look into the recent history of suicidal ideation and behavior in the past several weeks, and also look into the lifetime history of suicidal ideation and behavior. And this is very important, because sometimes that the youth can tell you that they are not having any suicidal ideation in the past several weeks, but the lifetime history of suicidal ideation and behavior is important, because this is the predictor of future attempts. So all this information is going to help you what intervention you're going to use and which pathway you're going to take for this child that will help to reduce his overall risk. So first of all, the assessment of safety is a priority. So we assess for suicidal ideation, the severity of the ideation, the level of intent and behavior early in the assessment. There is a myth that the clinicians sometimes they are fearful of asking kids about suicide because they think that will make the kid think about suicide, but that's not the case. Only youth with suicidal thinking will endorse suicidal thoughts. We also recommend using a standardized assessment, and this is the reason. The reason is because it increases reliability across time and clinician. So the next clinician who's assessing a child, they already have a framework and can understand the risk better. It has to be comprehensive, that can assess for risk and protective factors. It improves the identification of high-risk patient. Our clinical interview also identifies the highest risk patient, but this will also help us. It facilitates inter-clinician communication and help target our intervention efforts. We know that suicide ideation wax and wane over time. Our interventions also wax and wane over time. And it also supports ongoing assessment of recurring patients. So the instrument that we recommend is Columbia Suicide Severity Rating Scale, CSSRS. The reason we use this scale because it is well validated in multiple populations, it is well studied, it is freely available in different languages, and it gives the specific definition for the spectrum of suicidal ideation and behavior. And the reason, and this is very important because we want everyone to use the same language. It is applicable across multiple settings and languages, and it's freely available. And there are a lot of versions which are available. If I'm seeing a patient for the first time, I can use a lifetime version. If I'm seeing a patient for a follow-up, I can use since last visit version. And there are other versions for the ED setting, for the primary care. And the other thing is you don't require a mental health clinician to administer this scale. Anyone can do it. A police officer can do it. A first responder, EMT, anyone can do it. And then it is available in a pediatric version for children and adolescents. And this is the link where you can go and look at the scale. And it actually looks at four things: the severity of ideation, the intensity of ideation, suicidal behavior, and lethality. So the key points for suicide risk assessment are: you're identifying the suicide risk factors, or the chronic and the acute. You're collecting information from multiple sources. As compared to adults, in children, we collect information from the patient, from the caregivers, their school, their therapist. We use questionnaires for the parent, questionnaires for the child. We'll consider all the risk and the protective factors to help the risk formulation, which I'm going to talk about next. We use our clinical judgment to assess the level of risk, especially the acute risk. And we develop and implement a safety plan in collaboration with the patient and the family. And we make sure that there are no, that the house is sanitized, and there are no firearms or sharp objects in the home, and the medication are also in a safe place. And we also, it is very important to document your to support your decision making and care transitions, which means whether you are deciding to send the patient to a higher level of care or a lower level of care. Risk and formulation and interventions. So far what we have done is we have looked at all the information, or we have collected all the data. We have collected information from the school, from the parent, from the child. We have used a multi-method interview, clinical interview, and our standardized interview. All this is so the risk formulation is generated from the risk assessment. So it allows us to look at the unique combination of risk factors and protective factors that will inform us about the level, extent, and imminence of risk. So this is very important, because now this will help us. Now we have the assessment, we have the formulation. Now we have to decide which steps we need to take to reduce risk and increase safety. So are we sending the kid to a hospital because his risk factors are very high, or are we going to discharge him home and ask him to come a few days later to see us again? So if we decide to send a patient home and they're going to follow up with us a few days, we have to do safety planning. So what is safety planning? Safety planning is an intervention. So I have seen some people, like right before discharge from the hospital, what they do, they sit with the family for 5 minutes. They say, these are the warning signs. If you feel this way, call these numbers, keep the firearm away, medications away. But this is not the way to do safety planning. Safety planning is an intervention. It is developed by Greg Brown and Barbara Stanley, and it accomplishes a lot of different things, and we are intervening in a very specific way in a very acute time in patient's life. So basically, it helps to make a list of warning signs, coping strategies, and resources that the child can use in the time when they are feeling suicidal. So the target population is not the individual who we are sending to the hospital. The target population is those kids who we are sending home. And it is based on the idea that individuals who have trouble recognizing a crisis is beginning to occur, they use these skills to problem solve, to deal with that crisis. So what are the safety planning goals? We develop a plan that they can use when they are in distress. We engage the patient, we motivate the patient to use the safety plan. We try to develop a relationship with them. We empower the patient through knowledge. We teach them the self-monitoring, coping strategies, and we start with, we teach them how to use their internal resources, and if they don't help, how to move towards the external resources. We also communicate, we show them care and commitment that we are there to help them, and also their family is there to help them. What are the safety planning steps? First, you explain the goals of the intervention to the youth. You identify the warning signs. So this is very important. As a teenager cannot tell you that I just feel suicidal. You have to go for and identify concrete situation. For example, when my father yells at me because of my grades, I feel suicidal. Or my friends, when they leave me out of their gathering, I feel suicidal. So it has to be suicide specific. Then you explain it to them how to follow the steps of the safety plan. So typically, you look at the warning signs, then you teach them coping strategies. And the first step is the internal coping strategies, that what they can do when they are feeling suicidal, and instead of calling someone, what they can do to help themselves. This can be they can listen to music, they can go for a walk, they can take a shower, and if that doesn't help, they can call a friend and talk about something else, that can distract them. If that doesn't help, then they can go to a public place like Starbucks or some place where they're surrounded by people. If that doesn't help, then they can call a family member who is aware of their problem and talk about it. And if they really feel suicidal and they feel that all these things are not helpful, they can call the emergency line, they can call their therapist, they can you can tell them and problem solve all these different situations with them. You can tell them, if I'm not available during the daytime, or you're feeling suicidal after hours or on the weekends, you can give them numbers, they can call, you can give them the hotline numbers. But this is a stepwise sequence that they can do. They can use any of these steps, what they feel like. And then you talk to them, where do they keep the safety plan? These days, everyone has a cell phone. There is Stanley Brown has a safety planning app. So I go over with the patient and put all these things in a stepwise fashion in the safety plan app. You can also write down all these steps on a paper and give it to them and to the family. And the most important step is you have to make the environment safe. You have to talk to the family to restrict all the lethal means like medications, sharp objects, razors, ropes, firearms, all things to make sure that the environment is safe. I want to talk a little bit about non-suicidal self-injury. It has been linked to suicide, but typically it occurs for different reasons. It happens for higher repetition rate, and the driver is to comfort, not to die. It's associated with broader comorbidity, and death from cutting is very rare, and usually the teens tell you that I do it because my friends do it. So the key points for managing for patients with elevated risk in an outpatient setting is you collaborate with the patient, family, and the school system. You develop a safety plan and consistently refer to it and update it as necessary. You increase the frequency of outpatient visits if needed. If you're seeing a patient once a month, now you have to see them every week. You maintain contact between visits and follow-up when visits are missing. If they are not coming for an appointment, that's a red flag. You need to follow up with them. Ongoing safety assessment at all future visits is essential. You do Columbia on every visit that they come to see you. You seek consultation with colleagues if you're unsure about something. And it is very important to utilize a medical record to document and communicate the patient and share the safety plans and track the history of suicidal ideations and behavior. And engage all members of the treatment team, including medical providers, mental health team, and family members. So I'm going to talk a little bit about the intervention for suicidal youth. There has not been many evidence-based intervention for preventing suicide in youth. There are quite a few studies examining the youth who are coming to the emergency department, but much more is needed. So one of the brief intervention for suicide attempts, we have found that multiple ED studies examine treatment engagement of adolescents and families to decrease suicide behavior. And what we have found, like very few, less than 15% ever attend outpatient treatment following discharge. And once they do, 50% attend more than a few appointments. They have noted some improvement in outpatient treatment adherence, and many people identify access to outpatient treatment as barrier to continuity of care. And even when the continuity of care was provided, very few families came for the follow-up, and there was no significant reduction in suicidal behaviors or functional outcomes. There is one study, YST, Youth Nominated Support Program, that focused on higher risk period for suicidality, which is like 1 to 2 weeks after discharge from a hospital, and it targeted poor treatment adherence and what they found. A lot of youth have negative perception of family support and helpfulness. So in this study, the youth identified adults to support them following discharge. Psychoeducation was provided to them with weekly consultation, and they found the response was positive, and 80% of the nominated adults, they participated. And these nominated adults can be anyone. They can be family member, community members, but they participated in this intervention. They found that female participants were more, they took advantage of this intervention than the male participant. And also there was some improvement in suicide deaths in 11-year follow-up. So I'm going to talk a little bit about the suicide-specific interventions. There are some evidence-based therapy for suicidal ideation and behavior. We all know about the dialectic behavior therapies. It is an evidence-based therapy that focuses on helping the youth to tolerate the experience of distress and emotional pain, and we help them to develop the skills to regulate their emotions. There is also cognitive behavior therapy for suicide risk, and this is a very robust treatment. Safety intervention as of now it is a safe alternatives for teen and youth. It has both CBT and DBT family therapy components, and it has been rated efficacious in reducing suicide attempts. Attachment-based family therapy by Guy Diamond, it focuses on adolescent and caregiver attachment relationships. Other therapies that you can also use to mitigate risk factors are family therapy, group therapy, substance use treatment. So briefly about the pharmacological treatment for suicide prevention. We all know about lithium. There are many randomized controlled trials that have shown that lithium in a very robust way decreases death by suicide and suicide behavior. Depakote is also works like lithium but less than lithium. There was a landmark study by Melzer that have shown that clozapine has a robust effect on decreasing suicidal behavior in schizophrenia. So antidepressants have been known to reduce risk in adults. This is typically related to decreasing the depression. So in adolescent, we can use antidepressant when they are depressed, but we also recommend that we add CBT focused on suicide prevention or DBT along with the antidepressant. ECD also reduces suicidal thoughts, but it is not none of these things are approved in youth, but they're only for adults. And ketamine also is effective in some studies, but it has not been approved for youth. So what is the best intervention for suicidality for youth? Prevention is the best intervention. And the kids are usually in the schools, so the interventions which are provided in the schools are very effective. So school-based program and restriction to access of lethal mean is the best way to prevent suicide in youth. I want to mention briefly two interventions that are focused on prevention of suicide in youth in schools. One is SOS, signs of suicide. So this is currently being studied in many schools and found to be very effective. These interventions are easy to use, they're not expensive, and you don't need a mental health person to use the intervention. So in this intervention, it teaches the student the suicide doesn't come from too much stress, but it's related to mental disorders, just like this, for example, depression. And we teach them how to respond to depression and suicidal thoughts in self and others. The other study, which is very effective in reducing suicide in school. This study was conducted in Europe in 168 schools, and 1,100 students, pupils, they participated in the study, and they were randomized to either one of these three interventions or a control group. So what they have found that Students that were randomized to the YAM program, the Youth Aware of Mental Health program, that was associated with the reduction of suicide ideation. And in this program, they educated the youth how to protect their own mental health and how to recognize the signs of distress and what to do about it. There was a significant reduction in suicidal attempts and ideation compared with the control group 1 year later. So in terms of suicide prevention strategies, one of the most effective strategy is means restriction. So most of the studies are on firearm restriction, and gun availability increases the risk of suicide by firearms. There have been mixed results regarding effectiveness of restriction. So, but that means when we ask the parent to get rid of their guns when their kid is suicidal, frequently that doesn't work. But when we teach the parent how to keep the firearm safe and how to separate the bullets from the gun, that is more effective. We are prescribing less medication, opioids, analgesic, and we are putting barriers at popular jumping sites like bridges and railways. And this is important. Hanging and suffocation, it is hard to prevent because it's usually occur in private homes. Dr. Benton?
Next slide, please. So just to summarize, kind of the high points is that what we found to be successful as it relates to suicide prevention is means restrictions. Pesticides is a common cause of death in many lower middle income countries. Barriers work. Teaching the media to report in responsible ways. So there are media guidelines for how suicide should be reported in ways that don't glamorize or make suicide sound appealing. Improving our substance use policies and being thoughtful about how much we prescribe. Identifying youth who are in emotional distress or who have mental conditions or chronic pain. And then training everybody and taking a public health approach, not just mental health professionals, but community members to help recognize when people are in distress, to get comfortable asking about suicide and knowing how to respond if the answer is yes. It's important that we assure follow-up for people who made suicide attempts, even if they say, oh, I just did it because I was upset. Any suicide attempt is typically a signal of some other emotional problem. And then making sure we educate people so that everyone is aware that suicide is a risk for youth.